Good morning. Thanks everybody for joining us so early this morning. We are here to talk about CLL this morning. Hope is here. We are going to talk about oncology nurse strategies for delivering effective, compassionate, and modern care to patients. We have a little housekeeping to do. I am here with Kristen Badiato and Christina Rossamano. And thanks to PeerView for providing this session, and AbbVie, AstraZeneca, Bristol Myers Squibb, Pharmacyclics, Janssen for providing education for these grants. Thanks also to PeerView and the Cll Society. And so this is just our disclosures and other housekeeping, planning committee disclosures, unlabeled use disclosures. And then I want to encourage everybody to visit PeerView, and the URL is there. The slides, there are some practice aids. There are like really nice tools there that we've provided based on this program. So definitely visit that. So let's dive in. So where do we stand with CLL in 2022? There are about 20,000 cases diagnosed. That's the estimate for this year, about 4,400 deaths. So the median age at diagnosis, as those of you know who see these patients, this is an older population in general, about 70 years of age is the median age. And CLL and SLL, small lymphocytic lymphoma, are identical. CLL is classified as having greater than 5,000 clonal lymphocytes in the peripheral blood, whereas SLL patients don't have that high lymphocyte count, but they have lymphadenopathy. But to our pathologists, those are identical under the microscope. And fortunately, because of many of the new therapies that we are going to discuss today, the 5-year survival rate is 87% for CLL patients. So those of you who see CLL patients, you know we do a lot of active surveillance or observation, watch and wait, whatever you're calling it. And there are criteria for initiating treatment. And this is based on the International Working Group for CLL criteria. So patients need to have cytopenias or bulky adenopathy. You can see the list of things here, disease-related symptoms, a node sitting in a problematic spot, splenomegaly. So we're waiting for these triggers to initiate therapy. And it's really important that we all know this so that we can talk patients through that observation period, because that's not always the most comforting time for patients. So let's talk about new agents. So we've really come a long way in the last, it's actually less than 10 years. We've now got a host of new classes of drugs. We've got our Btk inhibitors, ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib. So acalabrutinib and ibrutinib are FDA approved. Zanubrutinib is in phase 3, as is pirtobrutinib. So these are coming. Zanubrutinib is approved for a mantle cell, so that does have an FDA approval. Venetoclax is our BCL2 inhibitor, and then we've got our PI3 kinase inhibitors, idelalisib and duvelisib, and those have limited indications at this point because of toxicity. We're not going to spend much time at all talking about that class of drugs. So why are we here? Clearly, we're here to learn about CLL. But despite progress with these targeted agents, CLL really is still a challenging disease. So chemo immunotherapy, things like FCR, BR, these are not anywhere in the NCCN guidelines as Category 1 preferred regimens. But in the CLL Inform Registry, which is sort of an observation study looking at treatment patterns and practice patterns, still 40% of patients with poor risk CLL are getting chemo immunotherapy, and they do not benefit from chemo immunotherapy. So clearly there's an education gap somewhere. So CLL patients previously treated with both BTK and BCL2 inhibitors, so our best drugs, really do have poor outcomes because our currently available options in that space are limited, and we'll talk a little bit about those. So our agenda today, we are going to do case-based lectures on treatment choices and talking about low-risk disease and high-risk disease. We're going to talk about sequential therapy, CAR T, future combinations, and all the way along talking about safety and management of these therapies. The CLL Society, I just want to shout this out for those of you who have not gone to this website or who do not direct patients there. There's a wealth of information for both us as healthcare providers and to our patients. There are support groups. They have co-pay assistance programs. There's lots of education for patients. There's really nice guidelines for COVID, in our age of COVID. So definitely worth looking and figuring out what you need and what your patients need. So we've got a couple videos embedded throughout this. And so our first patient is Jeff. And the team back in the back is going to roll this video.
I'm Jeff Grubbs, and I've been living with CLL for 13 years. I was diagnosed during a routine annual physical. I walked in feeling fit, happy, and no complaints at all, and I walked out with a high white blood cell numbers and a referral to a hematologist-oncologist. And I was diagnosed with CLL soon afterward. So I got pretty depressed. I was very angry, and a few months of therapy really helped, and I finally got adjusted to the watching and waiting. But treatment time arrived 5 years later. I was treated twice with high doses of a chemo called cytarabine that was infused into my spine. I was also treated with high doses of a Btk inhibitor, ibrutinib, which is taken as a pill. And that got me back into remission again. Those awful seizures stopped and most of my eyesight has returned. So I go to show that this disease is super different in different people and requires a lot of managing sometimes. And I've never thought that CLL is going to kill me, and I still don't believe it will. I've had so many great memories of the fabulous nurses I've met along the way too many to go through, but one of my favorites was Emma, who helped me with the intrathecal infusion of chemo. I was scared, having seizures, I couldn't really see, and then there were lots of delays. And Emma was with me step for step, and she was just a great advocate. And every nurse I've met along my way has just been so supportive and helpful. And I'm incredibly grateful for every single one. I hope that you urge newly diagnosed patients to use reliable sources of information and not general internet searches. The CLL Society is an excellent source of information about this disease, and the address should be up on the screen. CLL is a lifelong and sometimes very scary process, and it's super helpful for patients to be in touch with other CLL patients. The CLL Society sponsors patient and caregiver support groups around the United States and Canada. And patients just need to know and understand that there is lots of hope for CLL. The science is moving fast, and it's constantly producing really effective new treatments. This is a place to really learn about them. To wrap things up, I want to talk directly to all the nurses in the audience. Nurses are who we patients see the most, and that's where our relationships usually are. I've had times that I trusted the nurse much more than I trusted the doctor. Nurses are just the most important part of our care team, and I especially appreciate when nurses stick up for me when things are not going to plan. Infusions, complications, severe side effects, they're just the toughest part of treatment, and doctors don't often see them. We turn to nurses for help. CLL, it just isn't one size fits all. We can be extremely different, and being sensitive to us as individuals with all of our differences is just so crucial to gaining trust, and nurses are just really good at this. And most importantly, from my heart, thank you so much for you and your colleagues for just your amazing work. You've made a big difference to me, and I will be grateful forever.
What a way to start your morning, right? And now I'm going to turn over to Christina.
Thank you, Amy. Good morning, everyone. Thank you so much for being here. My name is Christina, and I hope everyone is adequately caffeinated. We are going to start now, delivering effective care now in CLL, nurse principles for managing treatment-naive disease. Upfront choices, continuous versus time-limited therapy. So first, we're going to start assessing next steps for a patient with high-risk symptomatic CLL. So meet Michael. He was 72 years old when he was diagnosed with asymptomatic CLL. He was monitored for 2 years. He's now 74, and he returns to clinic with symptomatic disease, including your classic B symptoms, fevers, night sweats, unintentional weight loss, anemia, so a hemoglobin less than 10, and abdominal adenopathy on imaging. He has comorbid hypertension and a creatinine clearance greater than 60. Testing shows unmutated IgHV and TP53 mutation. So these are poor prognostic factors in CLL. So what are the next steps? How should Michael be counseled on his disease and on his prognosis? And should we pursue continuous or fixed duration therapy? So we have to start by explaining modern goals of therapy to patients with CLL. It's very effective, but it has different goals. And it's important to actually empower patients and have them to be part of the decision making. So there are two avenues in front of us. We have continuous therapy. So this is Btk inhibitors, currently ibrutinib and acalabrutinib. These are medications you take every day or twice a day, like your blood pressure medications or your thyroid medication. Goals of therapy here are disease control, prolonged PFS, and independent from response, minimal residual disease. Second avenue, though, is fixed duration therapy, so time limited. An option here is Venetoclax, your BCL2 inhibitor, plus obinutuzumab, a monoclonal antibody. Goals of therapy are different: disease eradication, prolonged progression-free survival, and undetectable minimal residual disease. So these are the NCCN guidelines. BTK and BCL2 inhibitors are the preferred upfront treatment options in treatment-naive CLL. So for patients age greater than or equal to 65, or patients aged less than 65 with significant comorbidities, the preferred regimens are here in this gray arrow. You have acalabrutinib, your BTKI, plus or minus obinutuzumab, your monoclonal antibody, ibrutinib monotherapy, Venetoclax, your BCL2 inhibitor, plus obinutuzumab, and those are your category 1s, and also mentioned here is zanubrutinib, which is not yet approved in CLL. Again, coming down to patients aged less than 65 without significant comorbidities, the preferred regimens are actually identical. So what about high-risk settings? What about patients who have deletion 17p or TP53 mutations? Oddly enough, and this is not a trick, the preferred regimens are, again, identical. There are also some other recommended regimens, but the preferred regimens stay the same. The one thing that we learned from the past two slides is actually chemo immunotherapy is not recommended any longer, right? So the novel agents are recommended, but chemo immunotherapy is not. So here we just have some randomized studies that were done. Different populations, different designs, but basically the gist of this is that there was a PFS benefit from the experimental arm, and the experimental arm contained novel agents. So either your BTK inhibitor or your BCL2 inhibitor. Again, versus chemotherapy, PFS benefit with the novel agents. So if we look at a couple of these studies, there's longer-term evidence supporting continuous BTKI therapy. So in the RESONATE-2, we now have 8 years of follow-up data. This was ibrutinib, our first BTKI, versus chlorambucil, so BTKI versus chemotherapy in treatment-naive CLL. And of course, there was a PFS benefit with ibrutinib. 59% versus 9% at 7 years. It's astounding. Benefit in deletion 11q and unmutated IgHV patients. So now we see benefit in patients with high-risk genomic features. And overall survival at 7 years was 78% with ibrutinib. So again, our take-home here, sustained benefit with first-line ibrutinib treatment for CLL, including patients with high-risk genomic features. Moving on to our second generation acalabrutinib, the ELEVATE study. 4 years of follow-up data now available. Again, PFS benefit with acalabrutinib. There were 2 arms that had acalabrutinib, and both of those showed benefits over the obinutuzumab chlorambucil arm, the chemotherapy arm. So here are some studies that allowed for patient with TP53 aberrations. There's 3 of them here, and basically the takeaway here is that the patients who received the BTKIs did better than the patients who were on chemotherapy. So again, there was no BCL2 inhibitors here, these were BTKIs, but it does show the potent efficacy of the BTKI therapy in TP53-CLL. So what about fixed-duration venetoclax and obinutuzumab in TP53-CLL? Again, it's a regimen that's recommended by the NCCN. So although fixed-duration Vengi was effective in the CLL14 trial, the presence of deletion 17p and TP53 was associated with unfavorable prognosis. And if you kind of look at the graph there, your dotted lines are Vengi, no deletion 17p, and G-chlorambucil, no deletion 17p. So overall survival is okay. But then if you look at the solid lines, that's where you add in those 17p patients. And there's quite a disparity there between the 2 groups. So we have to explain prognostic factors to patients. Most of us in urban centers, we run this testing on patients at diagnosis, and it becomes part of what we discuss with them, as we're introducing them to their disease. So the 3 that are highlighted are actually the ones that affect our patient Michael. He has a TP53 mutation, he has IGHV status of unmutated, and he is greater than 65. So TP53 is just your suppressor gene, right? So again, if this is mutated, less control over the proliferation of cancer cells. Mutated and or deleted here is not good. IGHV, so this is we call this antibodies, helps with instructions for antibodies which help you fight infections. Unmutated, again, poor prognostic factor. And age greater than 65, again, you're likely to have more comorbidities the older that you are. So again, when we say poor risk factors too, shorter time to treatment, maybe shorter PFS, okay, this is what we're talking about. So the Cll Society Toolkit, this Test Before You Treat campaign, is super helpful for patients. We test FISH and TP53 mutation before every treatment. Why? Because these can actually change. IGVH mutation status, we test before first treatment. We don't have to retest this again. This does not change. Deletion 17p, no chemotherapy. TP53 mutation, no chemotherapy. We figured this out with prior slides we reviewed. IGVH unmutated, no FCR. I'll go as far to say no chemotherapy here at all. And IGVH mutated, possible FCR. You have to say it. Especially if there's a 13q deletion and you have good prognostic factors. There are studies, patients have gone into long-term remission after FCR with those prognostic factors. So you can't say no, also considering that's actually considered a time-limited therapy. So we're back to Michael again. We've counseled Michael on his expected prognosis using appropriate tools and resources. We've educated on the risks and benefits of continuous versus fixed duration therapy. And I believe a continuous BTKI option is an excellent choice for this patient, and that would be my recommendation based on the data provided. But we cannot say that fixed duration Vengi is not a reasonable option, considering patient preferences and goals of therapy. So I actually turn to my colleagues and ask, what would your choice be for Michael at this point?
I think that therapy with a BTK inhibitor is totally reasonable, but time-limited therapy with venetoclax or obinutuzumab is also totally reasonable. And as long as you go over what his goals are for therapy, and if he's okay with continuous treat to progression or intolerance, I think this is more than reasonable and will give him excellent disease control.
I agree. And I try to tell patients, no matter what you choose this time, the other option will still be available next time. So they're not closing doors on treatment options.
Very true. And considering the patient and their lifestyle is huge here, and we'll go into that a little further down the line. So before we move on, please take a moment to answer a follow-up polling question on counseling for goals of therapy with targeted agents in higher risk CLL. You can do that on your iPad, and as you do that, I will continue. So now back to Michael again. We assume that BTKI therapy is chosen, and our next step should include counseling on dosing and drug interactions. So let's start with ibrutinib, our first to market BTK. Okay? So for CLL, the dosing is 420 milligrams by mouth once a day as a single agent or in combination. We do administer the ibrutinib before a monoclonal antibody if they're to be given in the same day. Huge to note that the dosing for mantle cell lymphoma is actually higher. It is a different dosing. So it is 560 milligrams by mouth once a day versus the 420 for CLL. We encourage patients to take this drug the same time each day with a full glass of water, irrespective of food. And if administered with CYP3A inhibitors, we consult prescribing information for dosing modifications, and we'll go into that in a little bit. Again, reducing dosage to 140 or once daily for mild hepatic impairment, and even less for moderate hepatic impairment. Again, we'll get into this. Big thing with the BTKs, again, you want to remind them not to consume grapefruit products or Seville oranges, which are often found in marmalades. These are actually CYP3 inhibitors, so they can increase the drug concentration in the blood. I will be honest with you, and I think my colleagues can agree, we have never devastated anyone with the news that they cannot have grapefruit. Moving on to acalabrutinib second generation BTK, 100 milligrams by mouth every 12 hours. This is the same dosing in mantle cell and CLL. Administered with a full glass of water with or without food. If a dose is missed by more than 3 hours, it should be skipped and you take the next one at your regularly scheduled time. Again, there are some dosage adjustments. We'll kind of get into this. So be prepared to review drug interactions with BTK inhibitors when counseling your patients. I mean, we're all nurses, or most of us are nurses. This is what we do. We do med reconciliation, we check for interactions. This is a huge part of safety with our patients. So this is not new to any of us, and this is what we do standard practice. So this is kind of a busy slide, but it basically goes to show that there are some recommended avoid areas and dose reduction or dose increase areas based on other medications they're taking. You know, a big one is CYP3A inhibitors. You have your azoles, right? I mean, a lot of patients are on azoles. So it's really important that you check your interactions and your prescribing guidelines for these patients. One of the big things, though, to bring up is this gastric acid reducing agent. So these PPIs are proton pump inhibitors. At this time, you can't take proton pump inhibitors with acalabrutinib, which has been frustrating to some of us because this is the only approved second generation BTK right now. And a lot of patients are on proton pump inhibitors. So again, at this, you can give them H2 receptor antagonists like Pepcid, and you have to separate by 2 hours, but a lot of patients want their PPIs. So luckily for us, hopefully by the end of the year, there's a new acalabrutinib maleate salt, immediate release and suspension that should be coming out. Clinical effect is expected to be comparable, and regardless of use of PPIs and ingestion of food, it can be used. So that's fantastic. So we're back to Michael again, and we have a little bit of a change in scenario. So what if Michael had presented with a history of cardiac complications like AFib or poorly controlled hypertension? Assuming continuous therapy was still preferred, can understanding BTKI safety help us refine our patient care? So the honeycomb on the left here, common toxicities. I'm not going to go in depth here on all of these, just take a couple. If we're talking about cardiac, so hypertension, usually a later effect of BTKs. We monitor and we treat with antihypertensives. Bleeding is huge. It has an antiplatelet effect. It functions like an aspirin, thins the blood. There's a couple things to note with this. So you have to warn your patients. They can have petechiae. They can bruise easily. We need to know if there's overt bleeding, nosebleeds, bleeding when you go to the bathroom. These patients have to hold these drugs X amount of days before certain procedures. And they should call the office and they need to let us know so we can tell them when to hold these medications. Also, because of the high risk of bleeding, if there's any significant trauma, especially to the head, they need to be imaged. You know, you slip and fall. It's been all over the news lately, people who injure their heads, right? I mean, Bob Saget, right? So we have to be really, really cautious with these patients. Atrial fibrillation. This is the one that'll scare your patients the most when you're starting these drugs. Either they have a history and they don't need any more drama, or their heart is perfect and they don't want anything, they don't want to take the risk. But we talk about the risk of atrial fibrillation. It can occur at any time. Okay? And the best thing to do is just to educate them on the signs and symptoms of atrial fibrillation and what they should do if they should have any of these signs and symptoms. So general BTK inhibitor safety monitoring approaches, we've talked about some of these already. right? We really want to consider non-warfarin anticoagulation in patients with new AFib. Warfarin's hard to manage, okay? We want to make sure these patients who are on anticoagulation are also, their platelet count is kept above 50. Hypertension, we already talked about, managed with antihypertensives. We're going to monitor our patients for signs of bleeding. Arthralgias, we really didn't get into. These can be significant. We rule out other causes. We use supportive care for lower grade events, some Tylenol, whatever pain medication of choice your practice uses. You can recommend physical therapy, but sometimes you actually have to reduce the dose. And in my practice, I think there was only one time that we had to actually stop this therapy and change because of significant arthralgias. Monitor for infections and secondary malignancies, obviously. And again, you're going to watch these patients closely in the beginning. You're going to assess CBCs monthly, and then per practice guidelines, however your practice does it, you'll continue to monitor these patients. So guidance on AE is more typically associated with second-generation BTKs. The big one is acalabrutinib and headaches, right? You kind of expect your patients will get some headaches, typically resolve in the first 1 to 2 months of therapy, and they're managed really, really well with acetaminophen and/or caffeine. And I usually go right to caffeine because it's supposedly a miracle. For those patients who tell you they don't consume caffeine, they're going to have to get some caffeine pills, I'm sorry. But again, dosage reductions and interruptions are usually not necessary. And with zanubrutinib, again, not yet approved, but soon, we should be prepared to monitor for neutropenia. And so there you want to provide your patients with growth factor if necessary. Again, a complicated slide, but if you look at this first rectangle on the left, you have your covalent or irreversible BTK inhibitors. And they start with the least selective and move towards the most selective. So ibrutinib being first to market, less selective, more off-target effects. More off-target effects, more side effects, right? So acalabrutinib and zanubrutinib are more selective, so less off-target effects. And then if you move over to the non-covalent BTK, pirtobrutinib, again, this is a reversible BTK. These are more selective, less off-target, and there is no head-to-head for the non-covalents versus the covalents to know which one is actually the most selective. But the takeaway here really is that the newer generation have less side effects because they hit less off-target. So communication is key. We educate our patients on safety differences between BTK options, okay? And there's been a couple head-to-head trials in CLL. Ibrutinib versus acalabrutinib in Elevate, and then zanubrutinib and ibrutinib in Alpine, and both of them have shown less side effects in the newer generation, and especially a less incidence of atrial fibrillation. So, I mean, it's pretty significant. Ibrutinib in the Alpine, ibrutinib 10.1% to 2.5% with zanubrutinib. So before we move on, please take a moment to answer 2 follow-up polling questions on dosing and safety management with BTKI inhibitors. And now I'm going to pass the wand over to Kristen Battiato. I want to thank you all for your time. Go, girl.
Hi, everybody. Good morning. Thank you for getting up so early with us, and thank you to PeerView for having me. So I'm going to talk about Sarah here. She's a 73-year-old female with a recent diagnosis of treatment-naive CLL. She presents to our clinic with progression of disease in the setting of worsening lymphadenopathy, classic B symptoms. She has no major comorbid illnesses, and her creatinine clearance is greater than 60 mL per minute. Her prognostic testing shows she has a mutated IgHV without evidence of a TP53 deletion or mutation, or without a del17p deletion. Just want to note, testing for TP53 mutation and del17p deletions are 2 separate tests. Del17p testing is a FISH test. Testing for TP53 is a molecular test. Sometimes people don't know the difference. So what are we going to treat Sarah with? She's treatment-naive CLL, so we're looking at frontline therapy options. She's favorable risk CLL because she doesn't have any high-risk genomic features. So we can offer her the convenience of continuous BTK suppression. The BTK inhibitors, which Chrissy just reviewed, include ibrutinib and acalabrutinib. These agents provide excellent disease control, prolonged progression-free survival, independent from minimal residual disease. So the majority of these patients will not achieve MRD negativity. However, if that's not the goal of the patient, it's not always mandatory. These people can remain on these drugs, these monotherapy drugs, for years and years with excellent disease control. Then we have fixed duration with venetoclax obinutuzumab. This combination provides excellent disease eradication, prolonged progression-free survival, and the majority of these patients will achieve MRD undetectability, usually within the first year of therapy. These patients are able to stop therapy after 1 year and have a deep and durable remission where they can remain on treatment-free observation for many years after. So when you're considering time-limited therapy, there's a couple of key questions we need to ask these patients. There's an increased risk for tumor lysis with venetoclax and obinutuzumab. Can these patients stay adequately hydrated? They need to drink about 1.5 to 2 liters daily throughout their venetoclax ramp-up. Also, the venetoclax ramp-up paired with obinutuzumab is quite an extensive schedule. These patients are coming in frequently to clinic. And they have to bring their medications with them. Are they compliant with medications? They may even require additional supportive medications. Are they going to follow directions? Also, this regimen requires frequent, long clinic visits with multiple labs, IV hydration and infusions, and extra monitoring. Does the patient have transportation to and from clinic? Do they drive, or do they have family or friends who can take them to and from and who can adhere to this extensive schedule, especially in the first couple of weeks of therapy? Again, there's a potential for obinutuzumab infusion reactions. Are they prepared for that? Also, I want to note, some patients are high risk for developing tumor lysis, and we'll talk about that a little bit later, but we usually recommend these patients are hospitalized the first 2 weeks of therapy at least, depending on how they do. Are they willing to be hospitalized for that? All things we have to review before committing to time-limited therapy with venetoclax obinutuzumab. So time and time again, we've seen randomized phase 3 trials compare chemo immunotherapy to novel-based approach, and we've seen that the novel-based approach has a superior progression-free survival benefit. So in general, MRD rates are lower with continuous BTKI therapy, especially, like I said before, despite excellent disease control. So a lot of times these patients are able to be maintained with excellent disease control, but they're never going to achieve MRD undetectability, or they're going to be on therapy for years and years before they come close. And that's not always necessary for patients. Usually these patients have good quality of life, and this is a very good option for them. Also want to note there are multiple ways to check MRD. There's peripheral flow cytometry or flow cytometry in the bone marrow, and next generation sequencing as well. In contrast, people receiving venetoclax obinutuzumab, the majority of these patients will achieve MRD undetectability. 76% in the peripheral blood, as shown by this graph, compared to 57% by bone marrow. So, like I said before, these patients, the majority of these patients get a deep, durable remission and are able to proceed with treatment-free observation following the first busy year of therapy for them. So historically, we've seen patients with IgHV, mutated IgHV confers a more favorable prognosis for patients with CLL when compared to unmutated patients. We've seen this play out in the chemo immunotherapy era. Unmutated patients tend to have a better prognostic course with these novel agents, but when compared to mutated patients, it's still unfavorable. They have unfavorable outcomes. So we have Sarah here. She's sitting in our clinic today. She needs therapy. Sarah is leaning towards time-limited therapy. She drives. She's compliant with medication. She's ready to go. I'm going to kick this back to my colleagues here, Christina and Amy. Is this a reasonable treatment option for her? Would you do this in your clinic?
Absolutely.
Yeah, absolutely.
Yeah, I mean, she's a perfect fit for fixed duration therapy. And I think you can also assume this is probably going to be better for her lifestyle, because that matters.
Yeah, agree.
Yeah. Okay. It's a pretty big sell where we work too. A lot of patients prefer the time-limited therapy option. Okay. So when venetoclax is used in the front line, we pair it with obinutuzumab, and obinutuzumab is given for the first 3 weeks in a row, and then venetoclax is added on day 22 of cycle 1. When we're using it in the relapse refractory setting, we usually start venetoclax in the front and they'll complete the 5-week ramp up, and then rituximab is added after they complete the dose ramp up, and they have to be on the 400 milligram goal dose for at least a week before incorporating rituximab. Again, like I said, there is a 5-week extensive ramp up for venetoclax in order to mitigate the risk of tumor lysis. So anytime we're starting a new therapy with any patients, you want to do an extensive medication reconciliation list. I want to remind you guys, these patients are usually, the median age is 70. They have comorbidities. They're usually on a lot of cardiac medications, and you want to make sure there's no drug-drug interactions with venetoclax and these cardiac medications. Really important. If it gets complicated and there are dose reductions required, I advise involving a pharmacist who can help you navigate that. So there's a tumor lysis risk with venetoclax. So patients should be educated on what the signs and symptoms are of tumor lysis. This can include nausea and vomiting, shortness of breath, irregular heartbeat, clouding of the urine, lethargy, and joint discomfort. So when people are preparing to start venetoclax-based therapy, we usually have them increase their oral hydration 3 to 5 days prior to coming into clinic. We're also going to put them on an anti-uricemic agent such as allopurinol 3 to 7 days prior, and we're going to make sure that they have their drug and they're ready to go. We also want to assess if they're high risk for developing tumor lysis and consider hospitalization. So in order to assess if a patient is high risk for tumor lysis, we probably most likely have to get some kind of imaging. And any lymph node greater than 10 centimeters or an absolute lymphocyte count greater than 25,000 and any lymph node greater than 5 centimeters is considered high risk. Also, the presence of a high burden of leukemia involvement in the bone marrow, an elevated pretreatment LDH, or impaired renal function puts people at additional risk for developing tumor lysis. So you really have to look at the patient in front of you and see if their risk factor is going to go up, in addition to compliance. I always think of the older 80-year-old patient who's widowed, who doesn't really have a lot of family support at home, who doesn't like to drive at night. This is somebody you might want to consider admitting to the hospital for some not babysitting, but a little bit more aggressive monitoring, especially with impaired renal function. So we're going to do this in the outpatient setting. You're going to bring these patients in bright and early because it's a long day for them. You're going to get a set of pre-dose labs paying special attention to potassium, uric acid, phosphorus, calcium, and creatinine. And you want to correct any pre-existing abnormalities prior to initiation of treatment with venetoclax. Then you're going to go ahead and repeat tumor lysis labs 6 to 8 hours and again at 24 hours post-dosing. These patients are also going to receive IV hydration on days 1 and 2 of each weekly ramp-up, and they're going to continue allopurinol throughout their 5-week ramp-up as well. So what are the current recommendations for hydration and dosing of anti-hyperuricemics? Low-risk patients can get away with oral hydration, usually 1.5 to 2 liters daily. Intermediate risk patients, usually we give them up to 3 liters daily. And those high-risk patients who are hospitalized, they usually get IV continuous fluids while they're hospitalized. Allopurinol, usually we give a flat dose of 300 milligrams at our clinic, but you can dose it 200 to 400 milligrams per meter squared daily, and it needs to be adjusted based on renal function. If you're considering giving a dose of Respiricase for hyperuricemia, you want to rule out a G6PD deficiency. If you give Respiricase with a G6PD deficiency, you can cause a life-threatening autoimmune hemolytic anemia, and that could be quite problematic. So once you have that confirmed that there's no G6PD deficiency, you can go ahead and give Respiricase. Usually when the uric acid starts to get up around 8, we consider this. Where I practice, we usually give a 3 to 6 milligram flat dose. However, you can dose it at 0.2 milligrams per kilograms as a 30-minute IV infusion. There are no renal adjustments required. And usually, I've only had to give it about a dose or 2, but you can give it up to 5 days, which I've quite frankly never seen, but it's possible if needed. So venetoclax has AEs like all these other novel agents. The main thing that we see with venetoclax is myelosuppression, more in the setting of neutropenia, and we see this anywhere throughout their course of therapy. It's quite problematic sometimes. So what we do is we're aggressive with our growth factor support. We're very liberal with that in our clinic. Also, if it's grade 3 or grade 4, we'll consider antibiotics or even a brief hold, and once their counts recover, we'll go ahead and restart venetoclax. And if this is a recurrent issue, you can consider a dose reduction. GI events include nausea and diarrhea. They're usually quite mild. infection, upper respiratory, most common, autoimmune hemolytic anemia in 7% of monotherapy with monotherapy, and joint pain. So before we move on, let's take a moment to answer 2 follow-up polling questions on ramp-up dosing and counseling for goals of therapy with time-limited treatment. And while you do that, I'm going to remind you guys there's a free Cll Society Patient Education Toolkit binder for healthcare providers, and this includes information on targeted agent classes for the use of CLL. Okay. I'm going to hand it over to Amy now.
Thank you. So we've heard about our current first-line and relapse refractory options, and so now we're going to talk about what's coming, what's next. So we've got another video. This is Bob, and our folks in the back are gonna.
Hello, my name's Bob Levis. I have chronic lymphocytic leukemia, CLL. My journey began actually in 2002 when I was diagnosed with CLL. I was 51 on what would be an 8-year business assignment in Singapore. You know, your first thought there is, how much time do I have? You know, long story short, it worked. I got a 3.5-year remission, and the therapy saved my life at the time. I relapsed. Ibrutinib was FDA approved at that time. I went on ibrutinib. I still had CLL in my bone marrow, so I signed up for a second CAR T trial. So that summarizes 20 years and going with CLL. My nurse at Penn Medicine, her name's Ellen. I've been with her. She's been with me, caring for me for the past 5 or 6 years, starting with my second CAR T. She's excellent. Doing my EKGs, so my checkups, scheduling my next appointments, doing the blood work, discussing the blood work. I wouldn't have anybody do right now a bone marrow biopsy but her. She's excellent. They were trained, prepared. There was a dialysis machine outside in case they needed that for any kidney issues. They had tocilizumab ready to kill the reaction in case it got out of hand. And a completely different situation from my first CAR T. We have 39 support groups across the country. We've got 30-some hematology, oncology, CLL specialists on our medical advisory board. We have a website that gets 80,000 hits a week for those CLL patients looking for guidance, looking for help. Our tagline is "Smart patients get smart care." There's a lot of options out there for CLL. We talk about all of them at the Cll Society. To the nurses out there, I want to thank you for what you do. You've been with me for 20 years through 6 treatments, 4 clinical trials. You are a special kind of person. There's only one other person in my life who's been there like that with me through 20 years of trials and treatments, and that's my wife, Sue, and my 2 sons and their families.
Great, so another inspiring story. So before we dive into new options, we do have time for some questions. I'm going to ask you ladies 2 questions from the iPad, and you guys can figure out which one of you is going to take them. So I have a question about BTK inhibitors, and do you change your monitoring schedule? How are you, the longer patients are on them, and do you change that monitoring schedule specifically looking for progression?
Usually when we start a BTK inhibitor, we'll start the patient and we'll see them 1 week later for a lab check. Though there is low risk of tumor lysis with BTKI inhibitors, patients with high disease burden can have a little bit of lysis. So we always make sure everything's fine at 1 week. If everything's fine from there, we usually spread out visits to 4 weeks. And as the longer they're on the therapy, we can extend out to about 3 months. We usually don't go longer than 3 months without assessing the patient on therapy, but that's usually what we do. And we don't do it because we're looking for progression of disease. We're just doing it because we're looking to monitor our patients who are on active therapy.
Yeah, I agree too. When we start BTK inhibitors, we tend to get weekly labs for the first month. It's really practice preference. But we're also kind of navigating if they develop any AEs at this time. I feel like the majority of the time, the AEs are when you first begin therapy. So with acalabrutinib, this is when the headaches are going to sit in. With ibrutinib, they can have other arthralgias, myalgias, and you can help the patients kind of navigate these AEs and kind of reassure them that it gets better with time, and offer them some supportive care options as well.
Thank you. And then the next question is about Venetoclax and the use of growth factor versus holding drug. How are you deciding whether you're holding or you're giving growth factor or doing both?
So usually if it's around a grade 4, definitely we're going to hold Venetoclax and administer growth factor. Grade 3, we usually give what we tend to do is we'll give growth factor with close lab monitoring, and if they don't recover, then we'll consider a brief hold. Sometimes I have to bring these patients back, multiple times a week to monitor their ANC and make sure they're responding appropriately to the growth factor. So it's kind of like a case-by-case basis, but it does require some close monitoring, and it can be an annoyance for patients. But you don't want our patients walking around neutropenic, especially in a pandemic.
I agree with Kristen. Some of these patients actually do also require dose reductions. You don't want patients to live on growth factor. The benefit of these therapies is kind of lost if the patient has to come every 2 weeks for a shot of Neulasta or a pegfilgrastim. So again, sometimes you also have to consider dose adjustments, and it's a balancing act to find the dose that works for that patient. Everyone's different.
Yeah, thank you. I agree totally. So let's move on to our third patient. So we're going to talk about options after multiple relapses. So John is a 69-year-old guy. He got acalabrutinib as his initial therapy. He did well for 4 years. He progressed, and then he went on Venetoclax with rituximab, and he relapsed again, and he got a PI3 kinase inhibitor. He rapidly progressed. So he's got unmutated IGHV. He does not have a deletion 17p or TP53 mutation. So what are we thinking about for him? Would another just FDA-approved covalent BTK inhibitor be useful? Would Venetoclax be useful? Should he try something new? So in current guidelines, BTK inhibitors and Venetoclax are preferred options. So we've talked about this before. You've seen these slides. These are our preferred agents, and he's gotten these, and he's also gotten a PI3 kinase inhibitor. So this works in low-risk settings, also in high-risk settings, and again, he's got unmutated IVHG, and so he is a higher risk patient. Chemo immunotherapy is not a great option for this guy, even though he doesn't have a 17p deletion. So in general, if you start with a BTK inhibitor, and we alluded to this, if you start with a BTK inhibitor at progression, you go to Venetoclax or a Venetoclax containing with an anti-CD20. If you start with fixed duration Venetoclax with obinutuzumab, then you go on to BTK inhibitors. So for patients who are unable to tolerate ibrutinib, you can use a more, because that's our first generation drug, you can move on to second generation, either acalabrutinib or zanubrutinib or Venetoclax. So you can switch to a different BTK or go to a different class of drugs. I try not to do that because if patients are responding, abandoning a drug class is still a big deal for this patient population. But what about the patients like this gentleman who have double refractory disease? This is definitely a challenging patient population because we don't have really good options for those folks. Oh, and I just want to come back here. So he's been on a covalent BTK inhibitor. Right, so then sequencing to another one is likely not to be effective if he was progressing. So what strategies can we use? So we've got our non-covalent. So this is pirtobrutinib, which we talked about just a little bit. And so what this drug does is it can overcome the most common mutation that makes patients resistant or progress through our current BTK inhibitors. So that will be a great thing to come to market. This very much reminds me of the CML world with, all of the CML, the imatinib, dasatinib, nilotinibs, and who do you choose? I feel like we're behind the game with CLL because these drugs are so much newer for us, but we'll eventually get there to the same place where our CML world is. CAR T therapy is another option for these heavily pretreated patients. They're in clinical trials at this point. PI3 kinase inhibitors are unlikely to be effective. Chemo immunotherapy is unlikely to be effective. And he's already progressed on BTK inhibitors. So this is our pirtobrutinib. It is a non-covalent BTK inhibitor, and Christina talked a little bit about this. And it does overcome, it's active in patients who do develop this mutation that is the main cause for them being resistant to our other BTK inhibitors. And currently in clinical trial, the recommended dose is 200 milligrams daily. And so this is our response. Overall response rate is about 60%. So that waterfall plot, anything under the line is good. So you can see that the efficacy is great in this heavily pretreated double refractory group of patients. And this is really where we need more options. So this is really an exciting drug. And there are more of these also in clinical trials. So pirtobrutinib also appears to have the least BTK-mediated adverse events. And Christina talked about the off-target effects of some of these drugs. So every generation of these is going to hopefully be safer, less side effects, more well-tolerated. So you can see the bleeding and the bruising. If you just look at grade 3 and 4, they're quite low for all of this: bruising, rash, AFib, hypertension. So this really looks like a very well-tolerated drug. So what about CAR T in CLL? Who works with CAR T patients right now? Can I have people raise their hand? Okay, so we have a few who are in the thick of it. And so then I'm assuming most of you are going to be seeing CAR T patients when they come back to your practice. So these are our currently approved agents: Axicell, Brexicell, Lysicell, and Tisagen. And you can see they're for diffuse large cell, follicular, acute leukemias, mantle cell. You don't see any CLL, right? So these are all in clinical trial right now for CLL. So just a very thumbnail view of CAR T therapy. So patients have their T cells taken by leukapheresis, and then they are sent off to a lab where a retroviral or a vector is with anti-CD19 is engineered into those cells, and then they are given back to the patient where they expand and they respond to the tumor. That is really the Cliff's Note version. Right, so what are trials showing in CLL? So Lysicell. So this is patients in pretreated CLL patients. They failed or were ineligible for BTK inhibitors. They had high-risk disease. They failed at least 2 prior therapies. If they had standard risk disease, they had to fail at least 3 prior therapies. And so as you can see, these overall response rates are really stunning. 82% overall response rate in this very heavily pretreated patient population. And you can see the dark is the complete responses, and the PRs are the lighter stable disease, and then certainly there were some progressions. But this is really exciting, and so hopefully this comes to market for our patients with CLL at some point soon. And so looking at then that efficacy, you can see here in Lysis-Cell Transcend, again, this is a similar, hang on a second, okay, good. Okay, so here we go. And this is where I just want to bring your eye to this orange little line here. So the patients who failed both a BTK inhibitor and Venetoclax, so our very worst prognosis folks, really have a very similar curve to the patients who did not have high-risk disease and maybe did not fail all of those therapies. So progression-free survival median 18 months and 13 months in double refractory patients. So this is really better than anything that we have now. So hopefully coming soon to a clinic near us for CLL. And then treatment emergent adverse events. So again, for those of you who are in the thick of CAR T, you know this. Cytopenias, cytokine release, neurotoxicity. Those are the big ones. And so you can see that this absolutely occurs in this patient population with this drug. They are not insurmountable numbers by any means, and the more we use CAR T, the better we're getting at managing all of these side effects and keeping people safe. So just an overview of CAR T adverse events. For those of you who are sending patients for CAR T, they need to be prepared for cytokine release, neurological toxicities, tumor lysis can occur, B-cell aplasia, technically graft versus host disease. The severity is typically related to their disease burden, and it can be severe, fatal, or patients can have very mild symptoms. Typically occurs within the first couple weeks, and this is all about inflammation and you see massive increases in their IL-6 levels. This is just how these drugs work. So our take-home on managing cytokine release, you can see they have fever, they can have fevers, myalgias, headaches, hypotension, a whole host of issues related to cytokine release. The goal is to prevent that organ failure, but not stop the CAR T cells from working. Supportive care, tocilizumab, steroids are typically what are used. And again, those of you who are doing this, you're doing this every day and you know this. So a typical patient experience is on day 2 following CAR T, they get admitted with a fever, they develop headaches, their inflammatory markers are high, on day 3, on day 5, they start developing hypotension, they need fluids, oxygen, and they get tocilizumab at that point. So neurotoxicity, the cause is completely non-understood, these neurotoxicities. It is very unclear. High-risk patients tend to have higher disease burden, and those with cytokine release tend to have higher incidence of neurotoxicity. Treatment is largely supportive, although there are some drugs that you can give, but they can be very subtle, with little fine tremors, word finding difficulty, or patients can be confused and delirious and encephalopathic, can be very severe. Typically, it just gets better over time, which is fortunate. And that seizure risk, patients are on anticonvulsants to prevent that. So what would CAR T look like in CLL? So what you would do is find a patient who you thought would be a good candidate, you refer them in, and so you just need to educate them about that thumbnail of CAR T and cytokine release and neurotoxicity. But then for the majority of you, this third point is where you are going to see these patients. So when they come back to you after getting CAR T, so what's happening with those folks? So it's common for them to have cytopenias. They potentially may need transfusions, growth factor, things like that. They may be on anti-infectives. And then neurological symptoms may be lingering. The recommendation for these agents is that patients don't drive for 8 weeks because of the length of the lingering neurotoxicities. I saw a lady the day before I flew out here who had neurotoxicity. It wasn't severe with her CAR T, and I work in the outpatient setting, so I'm seeing patients when they come back to me. She had her ring finger on her right hand had this very fine tremor in it. That was her only lingering neurological toxicity. So, this is what you're going to be seeing when the patients come back to you. You will not get them with flagrant, severe neurological toxicities. They'll stay at the CAR T center. So the CAR T management team, you can see in bold, this is a very nurse-heavy process. It's a very complicated process. And so most of us have specific nurses who coordinate all of this, nurse practitioners who work with these patients. So really, at the consult, at pre-treatment, during CAR T, at follow-up, really their nursing is really part of the backbone of pulling this off. So recommendations for John. Excuse me, I'm sorry. So back to John. He's our 63-year-old who is now needing his fourth-line therapy. So, you have to, this is a bad spot to be in for patients. And so he needs to understand that our standard options are not likely to be helpful for him. Clinical trials are absolutely a good option for him. CAR T is another option. Getting him on a pirtobrutinib trial would be a great option. And so, this is where we need to make sure that our patients are aware of these novel therapies, offering them to them, referring them out to centers who have clinical trials. And so on that note, we have another question, two polling questions related to CAR T in challenging CLL patient populations. And then while you're answering those, again, we keep coming full circle with the CLL Society. They have very nice CAR T resources for patients. And again, as one of our video patients said, being led to reputable places to find information is very critical for this patient population. You can find a lot of very inaccurate things online. So sending patients to the right places is very helpful. And then coming first full circle, how should we be preparing for the future for caring for our CLL patients? So let's loop back to Michael. So he presents, our first patient was Michael. Remember, he presents, he's got treatment-naive CLL, he's got high risk factors. Is he a candidate for a novel strategy that combines combining multiple of these new agents? And so there are studies underway, ongoing, more coming, looking at fixed duration, guiding with that measurable residual disease, guiding the length of ibrutinib and venetoclax, trying to reach that negative measurable disease state. There are multiple studies combining these agents, and then there are triplet studies going on, combining a BTK and venetoclax with an anti-CD20 monoclonal antibody. So really is combining all of these better than using them sequentially. All of that's getting worked out, and will take a while to figure out, but coming, lots of trials. And then the early experience with ibrutinib and venetoclax. So the way this regimen works is that patients get 3 months of ibrutinib first to debulk them and reduce that risk of tumor lysis syndrome, sort of like with the obinutuzumab venetoclax, where they get debulked with obinutuzumab, and then they start the venetoclax after that lead-in 3 months of ibrutinib. And so as you can see, 3 cycles of single-agent ibrutinib reduce that tumor lysis risk really substantially in patients with high risk going into this combination of drugs. Only 2% remained high risk. So that will be something that you'll be seeing, just making sure that we're adequately debulking patients to keep them safe and prevent that fatal or serious tumor lysis syndrome. So what does this mean for all of you? What can you do to prepare for this? So different issues are going to arise when we combine these agents. They have 2 distinct adverse event profiles. You've got to be prepared for adverse events related to both or newer adverse events or more severe manifestations of those adverse events. There's a lot of concern about the these are in trials right now. There's concern about the financial issues with using multiple drugs up front. You know that these oral drugs can often take a lot of work to get them approved, so now think about getting 2 approved. And then educating patients and caregivers. As our patients said, they're going to ask you questions that they're not asking their doctor. And so you've got to be ready to answer those questions, or at least know where to point them to get good answers to their questions. And so our take-homes is, hang on for the ride. The CLL landscape is changing quickly, and it is going to continue to change quickly. We've got to be adaptable and, pivot quickly as these new therapies come to our clinics. Newer drugs are coming. They're here. They are going to come constantly. We will have new drug classes. We will have new drugs within our existing drug classes. And then just being prepared for CAR-T. In the CLL space, and we just have to stay vigilant and prepared. And I think that is the last slide. And so let's take a couple questions. I think we have time for a couple questions. Can you load the questions? I think the ones that are on the iPad we answered. Does anybody have questions while we're getting the iPad to load? Does anybody want to shout out a question? So they are currently paying for when we use them as single agent. They are currently paying for them. Do you guys want to? Sometimes it's a little fight, but in general, yes. Go ahead.
Medicare and Medicaid are tricky because you have to have there's a threshold of income. So a lot of the patients with Medicare and Medicaid wind up needing grants or financial support through other options like the CLL Society or other people who provide funding for these patients. It's a lot easier to get these drugs approved via commercial insurance.
Yeah, and the Medicare patients get in that donut hole situation. But all of these companies have assistance programs that they will help patients with, like Christina said, with grants. But that takes time and effort. Mm-hmm. And the patients have to, as you know, provide financial information, and that can be a challenge for some of our folks as well. Mm-hmm. Oh, thank you. Oh, thank you. Okay, so let's talk about MRD. So is it standard of care to check MRD at various points during a patient's treatment journey? That's a good question.
It is a good question. I know we look at a lot of randomized studies that are checking MRD, but it is actually not considered standard of care to check MRD, specifically when following the CLL-14 regimen after patients complete a year of therapy with Venetoclax or Venetoclax. It's recommended those patients just stop therapy. However, it's up to the physician preference, but again, it's not standard of care.
Okay, we have a few online questions. Thanks to the online group for throwing questions in. So this question is about CAR-T. So when we are sending patients to CAR-T centers, what is the timing from when they're sent to when the decision is made to when they are actually ready for therapy? That is a loaded question. I wish there was a firm algorithm for that. So typically, the decision about whether a patient is a good fit or not a good fit is a relatively quick decision. But then they have to go through some evaluations, and they have to have their cells harvested, and they have to be expanded. And a lot of these companies will tell you that it's going to take 2 weeks to expand their cells, and that's usually not the case. It usually takes longer than that. So, we're typically continuing to treat patients so they don't have big intervals without therapy. Mm-hmm. So there's really not a hard and fast timeline. I think there is on paper, but that often is not the reality of how it works, and I wish that was not the answer. So from online, what can we do to prepare for the emergence of non-covalent Btk inhibitors? Do you have any experience with the agent? Is there anything that we should be looking for?
Yeah, I work closely with pirtobrutinib or LOXO 305, and it has a really very good AE profile. These agents are tolerated really well. We're excited for it to come to market, whenever that may be. So it's, I really don't have much to say because these patients tolerate it very, very well. And I think it'll be a good tool in our toolbox for patients who have been exposed to Venetoclax or covalent Btk inhibitors with progression or intolerance.
Yeah, I think it's just important that once there is more information on this drug that's published, to just familiarize yourself with it before you actually try to advise patients on it. That's the most important thing.
We have another question about CAR T. It's complicated. Do you have advice on ways that we can easily explain this to patients who don't have many good treatment options? I would recommend you look at the Cll Society, but also the agents have patient education materials available. It is hard for lots of folks to wrap their heads around CAR T, which is why we have to understand it enough to explain it to them. We have so many questions here. Thank you, everybody, for asking these questions. So what is your experience, ladies, with managing patients who have progressed on both a BTK inhibitor and Venetoclax?
That's kind of a loaded question, too. A double refractory patient is in trouble, and this is when you would recommend they start pursuing CAR T-cell options versus a clinical trial. Depending on where they're getting care, they might need to, seek out clinical trials to prolong their care.
Yeah. Agree, 100%. We usually recommend clinical trials first.
Yeah. Great. And then what have you learned during COVID about safely managing patients who have no choice but to come into the clinic, for example, those getting time-limited therapies?
You want to take this? I think just, we've had a full clinic all throughout the COVID pandemic, and, standard precautions, wearing masks, social distancing. We've limited our visitor policy where they're, depending on the week sometimes they're allowed one person, they're allowed nobody. And just really reinforcing the CDC guidelines and helping patients, encouraging them to follow it. And get vaccinated and boosted is really key here. We know that they have suboptimal responses to vaccines, and I think that's the best we can kind of offer them, and just support them because they're very anxious about this.
Yeah, agree. I mean, and I think a lot of us attempted to keep patients who did not need to be there out of the office, so that there was less risk for the patients that did have to be there, because there are patients who could not avoid coming into the office. So we tried to keep them as safe as humanly possible.
And we're learning more about COVID-19 in this patient population as time goes on, and there have been some publications suggesting that patients who were vaccinated before they started their anti-CD20 maintained their immunity. So we have started, I don't know what you ladies are doing, but we have started, if we get a patient who's unvaccinated and they need to start anti-CD20, we will delay it, if possible, to have them get their vaccinations done. It's still sort of amazing the number of folks who have not yet been vaccinated. So,
and we'll give Evusheld, right? So
yes.
The prophylactic antibodies, especially to patients before they receive CD20 therapy.
Yep.
Absolutely.
Yep, 100% agree. Yep.
Okay. So can you discuss the best way to address lower grade arthralgias? I have a patient taking BTK who is responding well, is on therapy, but always brings these low grade issues. That's really their major complaint.
So again, the first thing you have to do is just make sure there's nothing else going on. There's no kind of autoimmune thing, so just make sure you check those markers. We usually just recommend, Tylenol or, pain medication as tolerated. We will recommend sometimes physical therapy to see if that helps. But other than that, patients who have these arthralgias that started with these drugs, you kind of have to try to see if they'll hang in there. If they can hang in, these side effects usually improve with time on therapy. But again, there are patients who've had to have either dose reductions or stop therapy because of them when it's extreme.
Agree. A couple things that we also do in our practice is, you can also consider a brief hold depending where they are in their therapy. If they're just, if it's the first month of therapy, you try not to do that, and you try to kind of like get them through with symptomatic support, with supportive care. But consider a brief hold or even a short course of steroids, and sometimes that just kind of resets things, and they tend to tolerate drug when they're re-challenged with it. Also, sometimes I recommend topical Voltaren cream. Patients either love it or hate it, but it's another tool. It's a topical NSAID you can use. But those are some ways we can help navigate them as well. And and usually just reassure them. It's usually, worse in the first couple of weeks of therapy, and then it tends to abate. But then sometimes people struggle with it throughout their whole course of therapy, and you have to either consider a dose reduction or even switching agents.
Due to CLL patients being immunocompromised, are there any particular supplements they should or should not be taking, even if they are treatment naive? Does living in a COVID world affect that, and how might those supplements affect treatment?
The physician I work with does not love supplements. They tend to, so a lot of times if you're on therapy, supplements can be problematic as they can interfere with the therapy you're giving, whether they're BTK or Ven. But I know there's a lot of research out there. If you're on observation, we don't particularly recommend a particular supplement, but there's no, and you have to check for drug-drug interactions with the other agents you're on, obviously, if you're on other cardiac meds, or, you just want to run it by a pharmacist and make sure you're not doing more harm than good. But we don't have any specific recommendations.
Yeah, same. Patients who are not being treated are on a bunch of supplements. That's usually okay. You really have to watch out for the supplements that increase risk of bleeding, especially if you're on therapy like turmeric, even your omega-3s, right? So, you got to be really cautious with the supplements, but, it's an important communication, right? You just have to talk it through.
Mm-hmm. So here's a good question. Is bone marrow transplant still an option?
I think that we try and navigate all other potential therapies before proceeding with a bone marrow transplant because it's extremely toxic. But for younger fit patients who have blown through multiple therapies, it's definitely something we're going to keep on the back burner as an option.
Yeah. You don't see it often, but it's there.
Right. Yes, and we don't have CAR-T approved yet for CLL, so I think the real shift will come when we actually can use CAR-T consistently. I think we've hit the major families of questions. Does anybody out there have a burning question that we haven't? Some of the themes are repetitive on the iPad. Did I miss anything that someone does not want to leave here not knowing? Okay, well, wonderful. Thank you for joining us. I hope you enjoy the rest of the conference.
Thank you.
Thank you.